there will be two lectures, lecture 2 and lecture 3. So lecture 2 will cover dermatohistopathology and lecture 3 will be on primary and secondary skin lesions. Okay, these are the types of lesion and the terms that you need to know when you want to describe the lesion associated with the integumentary system. Okay. Okay, so for lecture 2, we'll be looking at the changes in the epidermis, dermis, and also the subcutaneous layer. So first of all, as I emphasized last lecture, you need to memorize all this diagram of the normal structure of the skin. So please remember the epidermis consists of a few stratum, stratum corneum being the outermost layer, followed by the stratum granulosum, stratum spinosum, and the innermost layer of the epidermis is the stratum basale. Right? Okay, so what are the epidermal changes that you might see? First of all, you can see hyperkeratosis. So hyper meaning there is increase or more. So here keratosis means that there is increase in the thickness of the stratum corneum. This can be absolute. Usually this is very common finding, or it could be relative, which is rare. What do I mean by this is that absolute meaning there is an actual increase in the thickness of the stratum corneum. Relative means that you think there is increase in the stratum corneum thickness, but in actual fact, it is due to the thinning of the underlying epidermis that makes the stratum corneum appears very thick. Okay, so it's like a false impression actually. So that's why it's called relative. Then hyperkeratosis can be further classified into two types. The autokeratotic, which means there is no nuclei, so anuclear, and the second one is called parakeratotic, where you can still see the nucleus. So remember, stratum corneum in normal condition, it is made of dead tissue which are anucleated, right? Okay, then this hyperkeratosis can occur either generalized, meaning the whole length of the tissue specimen that you see the similar thickening throughout the whole layer of the epidermis. It can also be focal, meaning you can only see at one spot or one localized area in the section of the skin. So this is called the vertical thickening or hyperkeratosis. Okay, hyperkeratosis is very, very common finding. So most of the time they say it is non-diagnostic. You can see diffuse parakeratotic hyperkeratosis most consistent in cases of ectoparasitism, dermatophilosis, dermatophytosis, even in cases of malassezia, dermatitis, and zinc-responsive dermatosis. Diffuse autokeratotic hyperkeratosis usually are suggestive of nutritional deficiency, secondary seborias, or maybe due to developmental abnormalities like ichthyosis, follicular dysplasia. So don't worry so much about these diseases because it will be covered in more detail in the following lectures according to the title of the lecture, like for viral diseases, it will be covered in lecture 6 and so on. Okay, so this today is just to familiarize you with all the terms that you would be hearing when it comes to lesion in the integumentary system. Okay, so when you have hyperkeratosis, definitely you can also see hypokeratosis. So hypokeratosis is total opposite of hyper, meaning there is decreased thickness of the stratum corneum. This is, however, very less commonly observed. The reason could be there is exceptionally rapid epidermal turnover time. or even maybe because of the reduced cohesion or both of this factor between cells of the stratum corneum. So meaning that remember from basal stratum basale, the cells will be produced and then it will travel upward until it reaches the stratum corneum. Usually it takes about 21 to 30 days. But in this case, there is very rapid turnover time, meaning usually lesser than that time, maybe 2 weeks time. So that's why the stratum cornea appears thinner than the normal condition. And then maybe because the cohesion is reduced, so that's why there's even more sloughing off of the stratum corneum, leading to the appearance of the uh, hypokeratosis. Okay, and then yeah, so as I mentioned, exfoliative action or seborrheic skin diseases can actually lead to hypokeratosis because exfoliation meaning you scrub on the skin too much, so you tend to remove the stratum corneum. Okay, and then maybe sometimes when you apply topical medicaments very roughly, also you can actually induce hypokeratosis. And then this is also common finding in intertriginous area. Intertriginous area means area between like fingers. Okay, so those are constantly undergoing friction. So that's why there is hypokeratosis because of the sloughing off due to the friction. Okay, another epidermal changes that you might see is the dyskeratosis. So dyskeratosis is actually premature and faulty keratinization of individual cells, meaning you only see single cells showing this premature or faulty keratinization. Okay, so how does these cells look like? Usually the cells with dyskeratosis appear very reddened. The cytoplasm is very reddened and it's usually larger in size because it's swollen. The nuclei is always condensed and dark staining, and this can cause confusion because it appears similar like necrotic keratocyte. Okay, this keratosis is commonly found in cases of papilloma, squamous cell carcinoma, and seborrheic complexes. Okay. All right. Next, we move on to the stratum granulosum. So, stratum granulosum can undergo hypergranulosis or hypogranulosis. So, hyper meaning there is increased thickness, whereas hypogranulosis means there is decrease in the thickness of the stratum granulosum. This is also a common finding. Therefore, it is often not helpful in diagnosis of skin diseases. All right. So this is a diagram that I cannot emphasize more for you to memorize the normal structure of the skin. Right. So remember the usually for thin skin, the epidermis is not that thick. Even the stratum cornea is not that thick. Okay. Right. So this is example of hyperkeratosis. Can you see this area, especially where there is increase in thickness of the stratum corneum?
Yes,
You guys can see,
doctor.
right? Yes, all right. So this is a very good example of hyperkeratosis. So if you see the whole length of the tissue section shows hyperkeratosis, then it is a generalized finding. However, if it's localized in one spot, then it means that it is only a focal hyperkeratosis. Okay, right. Okay, this diagram can be confusing. If let's say I did not reveal that this is actually thick skin, you might think that there is hyperkeratosis, right? Because of the thicker area of the stratum corneum here in comparison to the thinner stratum corneum as indicated by the arrows. So this is actually thick skin. So this area is actually showing hypokeratosis, thinning of the stratum corneum, right? Okay, so just now this keratosis, I remember I mentioned how the cells look like. they are usually larger in size. Cytoplasm are usually redder or eosinophilic than the normal keratinocytes. And if you look at the nuclei, they are usually more condensed and dark staining compared to the normal cells. Okay, so these are example of these keratocysts. Usually they occur singly or individually, not in a very big cluster or in a whole, or it should not occur throughout the whole tissue. Usually individual cells. Okay, so common finding in like squamous cell carcinoma, for example. Okay, all right. Next would be hyperplasia or otherwise known as acanthosis. So hyperplasia or acanthosis is increased thickness of the non-conified epidermis due to increase in number of epidermal cells. Okay, acanthosis specifically indicates an increased thickness of the stratum spinosum. So this one you can always see in cases of chronic actinic radiation or chronic exposure to UV radiation or the sun, and even cases of papilloma. Okay, and then of course the opposite one would be hypoplasia or atrophy, whereby there will be decreased thickness of the non-conified epidermis due to the decreased number of cells. Okay, so atrophy due to decreased size of cell can the size of cell, because they are small, can also lead to the appearance of atrophy. So this is very common finding hyperadrenocorticism and severe malnutrition. Okay, so example here on the left hand side is the hypoplasia or acanthosis, whereby you can see the epidermis layer is actually very thickened. Okay, so it is mainly due to the thickening of the stratum spinosum in the middle, right? In comparison to here, on the right side, the image here shows epidermal atrophy. So I hope you can appreciate the difference. Right, okay. Right, yeah. Next, we have necrosis or necrolysis. So this is basically death of cells or tissue. So typically these cells will appear, do you recognize the nucleus usually show the typical characteristic of dead cells. It can be either karyorrhexis, pycnotic, or even karyolytic. So I hope you remember your Pathol 1, because these are the terms that are taught during Pathol 1, your basic pathology, right? Karyorrhexis. Remember what is karyorrhexis? Anyone can recall?
Fragmentation of nucleus, doctor.
Right. How about pycnosis?
Shrinkage of the nucleus, doctor.
Okay, very good. And karyolysis?
Fading.
Sorry?
Nuclear fading.
Fading, or it is lost. You cannot see the nuclei anymore. Okay, all right, very good. So you can recall. All right. So keratocytes, usually they will sort of the connection between keratocytes are usually lost. Okay, so so you see the intercellular bridges are not obvious anymore. And then the cytoplasm also appear very reddish or eosinophilic. And then usually necrosis tend to occur in a cluster or focal, so they can appear either coagulated or caseated. Okay, for coagulated, meaning that usually the cell outline you can still see. Okay, but the cellular detail is lost. But caseated, meaning that there is complete loss of all structural detail. You cannot see any nuclear or nuclear detail or even the outline of the cell. So that's the difference between these two. And then this is a normal finding in cases of drug eruption where you see focal type of distribution, even also in microbial infection. Generalized necrosis or necrolysis are often described in cases where there is vasculitis or maybe due to immunological disorder. Okay, right. Next, we have intercellular edema. So as the name implies, intercellular meaning between cells, okay? So another name for intercellular edema is also called as spongiosis. What you would see is that there will be widening of the intercellular bridges. So intercellular bridges are the spine-like structures that host cells together. So when there is intercellular bridges, there actually is a bigger gap than normal condition. Okay, so you see the spines are these are the intercellular bridges. So here you see very obvious that the intercellular bridges are lost, and then there is increase in the gap between the cells. Okay, so this can be seen in cases of acute or subacute dermatosis. Any skin disease, you might always see this. This is like early changes of skin lesion. Okay, in many skin diseases. Okay, and then when you have intercellular, of course, there can be intracellular edema. Intracellular meaning the cell, there is edema inside the cell. So the cell will end up being larger in size, and the cytoplasm usually appear very pale. And then there could be displacement of the nuclei to the periphery. So this can be confused because artifacts also can induce the same type of change, especially in cases where the tissue was subjected to freezing or there is a delayed fixation of the tissue. Okay. Intracellular edema, okay, you might see ballooning degeneration. So this is a specific feature of viral infection. Okay, so what happens is that the cytoplasm of the cell will become swollen and more redder or eosinophilic, but there is no vacuolation in the cell. And nuclei will often be enlarged or condensed and occasionally multiple. Okay, for hydropic degeneration, there is intracellular edema of the stratum basale, okay, usually associated with a condition like lupus erythematosus or even drug eruption. Okay, so these are example. On the left hand side here is example of ballooning degeneration. So you can see that the cells are definitely larger in size. The cells appear paler than the normal cells. And then this is example of hydropic degeneration. Okay, so you see that there are vacuolation in the cell as indicated by the arrows. Okay. Right. Next, we have acantholysis. Acantholysis is basically loss of cohesion between epidermal cell resulting in intraepidermal cleft, okay, formation of cleft, vesicle, or even bullae. So this may be caused by a condition like severe spongiosis, ballooning degeneration, and even proteolytic enzyme released by certain inflammatory cells like neutrophil or even eosinophils. Okay, they do have some proteolytic enzyme that causes the loss of cohesion between epidermal cells. And then you might also see exocytosis, whereby this is basically migration of inflammatory cells and or erythrocyte through the intercellular spaces of the epidermis. This is normally seen in inflammatory dermatosis, vasculitis, or even coagulation defect. Okay, so here is a diagram to show you acantholysis. So this is part of the normal skin. So when there is loss of cohesion, so you see some of the keratinocytes are separated and then it forms a cleft. So when there is exocytosis, remember exocytosis is migration of RBC or even inflammatory cells. So they will go into the empty space created by the loss of cohesion of cells, and this would create, if in case of PAS2, you should expect the neutrophil, right? So yeah, so this is a typical finding in cases of pemphigus foliaceus. Okay, pemphigus foliaceus is where the body produces immunoglobulin that attacks the desmosome, the structure that holds the keratinocytes together. So when the antibody attacks this structure, so that's why there is loss of cohesion between the cells. Okay, and usually these skin usually are prone to get secondary bacterial infection, thereby you get to see the formation of pustule, okay, because of the migration of the neutrophil. Okay. Next, cleft or lacunae. These are basically slit-like spaces. Slit-like is very narrowed, okay, that do not contain fluid, okay. Usually within the epidermis or at the dermo-epidermal junction. And this might be caused by acantholysis or hydropic degeneration of the basal cells, although it may also be handling artifact. So the cleft here is indicated by the red arrow. So you see this white colored outline outside of the basal layer here. So that is actually the cleft, okay, or slit-like spaces. Usually it doesn't contain fluid, yeah. So don't confuse it with cyst or even other like pustule, for example, okay. So the green is the basaloid cell, and these are, these cleft actually are common finding in cases of basal cell carcinoma, for example. Okay. Alright. Next we have microvesicle, vesicle or bullae. So microvesicle meaning is microscopic. You cannot visualize it or you cannot see it with your naked eye. You need to view it under the microscope. Vesicle you can appreciate grossly, and bullae are actually bigger size. Okay, so this I'm sure all of you have experienced this type of lesion. For example, if you wear new shoes that are too tight, then you tend to get these blisters on your feet, right? So these macroscopic or microscopic fluid filled relatively acellular spaces within or below the epidermis. So this should be differentiated from like pustule. Pustule means there is pus. Okay, this one is clear fluid, so no cells inside the fluid. Okay, these changes can be due to ballooning degeneration, acantholysis, subepidermal edema, intracellular or intercellular edema. Okay. No, this is a diagram, this is a diagram that shows how a vesicle looks like. So this is usually fluid filled in the epidermis layer, okay? And grossly, this is what it should look like. You can see like a blister formation on the skin, okay? Usually, if you pop open the blister or even the vesicle, you should see very clear watery discharges coming out from the vesicle or blister. This is example of a case of swine vesicular exanthema caused by calicivirus. Okay, right. So this one should be differentiated from vesicle or blister because microabscesses or pustule are actually cavities filled with inflammatory cell. Microabscesses meaning is not visualized, it cannot be visualized from your naked eye, but pustule is something that you can see from grossly. Okay, so those are basically macroscopic or microscopic. Intraepidermal, meaning it can happen in the epidermis layer itself, or maybe below the epidermis, so subepidermal. Okay, and usually these are cavity filled with inflammatory cells, usually the neutrophil. Okay, this example of a pustule. So this is subcorneal, because you can see here is the stratum cornea made out of the dead keratinocyte with no nuclei, right? So it is below the stratum corneum. That's why it is called subcorneal. And then if you can see here, the larger paler ones are the keratinocytes, whereas the darker nuclei those are actually the inflammatory cell, and mostly are the neutrophils. So this is subcorneal pustule with numerous acantholytic cells mixed with neutrophil. Again, this is as a typical example of pemphigus foliaceus. Okay, right. Next we move on to hyperpigmentation, or otherwise known as hypermelanosis. So remember, melanocytes are usually found near the stratum basale. So that's why you can see these changes, okay, in the epidermis, right? So hyperpigmentation is basically excessive melanin deposited within the epidermis, and often concurrently in dermal melanophages, because sometimes the macrophages, when there is a melanin pigment, free melanin pigment, they usually engulf, so they will also take up the stain. Okay, they become pigmented. Okay, and this hyperpigmentation can occur either focally, or even it can occur diffusely. Okay, diffusely meaning a wide area of the body is affected. Causes of hyperpigmentation can be due to chronic inflammatory dermatosis, developmental or neoplastic disorder. Neoplastic disorder meaning example like melanoma. Okay, so so I hope you can appreciate these images where it shows these dogs are actually showing hyperpigmentation. Here in the on the left side, the dog is having hyperpigmentation of the backside order, maybe around the perineum area, and here at the inguinal area, and also the thigh. Okay. Okay. Definitely when you have hyperpigmentation, there can also be hypopigmentation or hypomelanosis. So this is basically the opposite. What do you expect to see would be decreased melanin in the epidermis. Hypopigmentation can be due to congenital or acquired idiopathic defects in melanization. Okay, congenital or acquired. So congenital, maybe like in this case, this is vitiligo. Okay, this is actually the hand of a dark colored person, but because of the defect of melanization, there are areas of the hand that are white in color, or maybe paler in color. Okay, it's not the normal skin color of the person. And can you recognize the breed of this dog?
Rottweiler, doctor.
Yes. So what is the normal color of a Rottweiler?
Black, dark.
Black. Yes. Usually they are black in color with 10 points, right? So this is not Photoshop image. This is actually a dog with vitiligo as well. So there is defects in melanization. Also there is not enough formation of melanin pigment to give the color to the skin, or even the hair coat. Okay. Hypopigmentation also can occur in other conditions. For example, toxic exposure to monobenzoate ether in rubbers or plastic, inflammatory disorder, for example, lupus erythematosus. Leukoderma is actually localized skin reaction towards injury. For example, maybe a person had a burn wound on the skin. As the healing occurs, okay, maybe there is that affected area, the melanocytes are not functioning. So when they are not functioning, the healed area will not have the melanin produced. Okay, so that's why when you look at the scar tissue of that area, usually is paler. Okay, so that's leukoderma. Can be due to maybe frost, any type of injury, abrasion also. When the injury heals, maybe because of the defect or defect in the melanocyte, that's why the healed area become paler than the surrounding area. Okay. Alright. Other changes in the epidermis can be crust. So crust is basically consolidated, desiccated meaning dried, surface mass, okay, composed of varying combination, either keratin, serum, cellular debris, and often microorganism. So this crust can be classified into different types depending on what it is made of. For example, in the left-hand side image, you see this person. These are crusts made up of serum. Okay, so the color is yellowish. If there is blood, then it is hemorrhagic crust. Okay, when you have inflammatory cells or even mixture, then you have serocellular. Okay, so it's basically exudative type of lesion where there is serum mixed with inflammatory cell or maybe like pus appearance. Okay, so it's depending on the nature of the crust. Okay. Right. Next, we have horn cysts, or sometimes known as keratin cysts. So these are structures, usually circular cysts, surrounded by flattened epidermal cells. So this is an important keyword. Circular cyst structure surrounded by flattened epidermal cells. And they usually contain concentrically arranged lamella keratin. This is normally seen in cases of basal cell tumor. So the arrows are pointing towards the keratin cyst, right? So this one you need to differentiate from horn pearls, or sometimes known as squamous pearls. Squamous pearls are actually focused circular concentric layers of squamous cells. Okay, squamous cells. So you can see that these are mainly squamous cells. Okay, showing gradual keratinization towards the center. So the pinkish one is actually keratinization. And you can always see also this keratosis scattered within the lesion. So this is very characteristic for squamous cell carcinoma, so-called like pathognomonic lesion lah. If you see horn pearls, definitely you can or you can safely diagnose the case as having squamous cell carcinoma. Okay, so please differentiate between the two. Alright. Question time. Which is which? Well, which image shows parakeratotic hyperkeratosis and which image shows autokeratotic hyperkeratosis? Anyone would like to try?
Doctor, it's orthokeratotic, the first one, and the second one parakeratotic.
Yes, very good. How do you know? How can you tell? Can you tell our friends?
Because orthokeratotic, it's the cells are anucleated, and then parakeratotic, the cells are nucleated.
Yes, very good. So you can see here the stratum corneum is very thickened and there is no nuclei in the stratum corneum. So it's autokeratotic in comparison to image number 2 whereby the stratum corneum is definitely thickened but there are still nuclei. Okay, so these are parakeratotic hyperkeratosis. Alright. Okay, very good. How about this one? which one is called intercellular edema and which one is the intracellular edema? Anyone besides another person can try.
Is the first picture intracellular edema and second intercellular edema? Doctor?
Yes, very good. Very good. Yes. So for the first image, again, you can see that the cells are larger, paler in color. So this is basically edema inside the cells, right? So intracellular edema, and this one is intercellular, where you see gap in the between the cells. So intercellular edema. So very good. You guys are paying attention. Okay, we are done with epidermis layer. Now we move on to the dermal changes, okay? So the first one is the dermal collagen. So you know in the dermis we have a lot of collagen. Example of dermal changes involving the dermal collagen, you can see collagen hyalinization, whereby you would see confluence and increased eosinophilic glassy refractar appearance. Okay, meaning you cannot see the individual collagen fibers inside in normal condition. It becomes confluence and then it's always eosinophilic, sometimes refractile when you view under the microscope, meaning refractile meaning like it gives like macam apa like shining, it feels shining, glassy, okay. And then this is commonly seen in cases of chronic inflammation. You can also see fibrinoid degeneration. There will be deposition on or replacement with a brightly eosinophilic fibrillar or granular substance that resemble fibrin. This is very typical in connective tissue disease. Other changes involving the dermal collagen include the lysis, degeneration, dystrophic mineralization, and even atrophy. Okay. Okay, this is next we move on to fibroplasia, fibrosis, sclerosis. This is basically scar formation, okay. This is very common in horses, for example. Okay, what is fibroplasia? Fibroplasia is actually formation and development of fibrous tissue in increased amount, okay, forming granulation tissue. So in the dermis, you know that there is fibroblast, usually not that much, but in cases where there is injury and there is need to repair the injured skin, so definitely these fibroblasts will become active. There will be more fibroblasts there in the tissue to help with the production of granulation tissue to help with the healing process. Okay, so it starts off with fibroplasia and then it will become fibrosis. Okay, so after that there will be fibrovascular proliferation, because fibrovascular you need more blood supply to the area where there is healing occurring. And then prominent fibroblasts, here you see more fibroblasts, very obvious fibroblasts in the tissue. And then edema and inflammatory cells are also constant features of fibroplasia, okay. So these are the first steps towards in skin tissue healing of the skin, followed by fibrosis. So fibrosis is a later stage whereby the fibroblasts and collagen fibres are increased. Okay, fibres are usually very prominent in comparison to the fibroplasia. The last stage is called the sclerosis or formation of scar. So this is the end point of fibrosis, whereby the most typical finding would be collagen fibres will be increased and the amount of fibroblasts is reduced, because you don't need more fibroblasts there because healing is already completed. Okay, so this is, as I mentioned, common disorder or common condition that you might see in horses especially. This is called proud flesh or exuberant granulation tissue. So histologically, what you see is that there is vertically oriented capillaries here. capillaries, the blood vessel, because you need the blood vessel for tissue healing, right? And then you can always see horizontally oriented fibroblasts. Fibroblasts are all the spindle cells, okay? And then a few collagen fiber provide a lattice work appearance so that the granulation tissue will become strong, okay? So collagen fibers are usually like strands of pinkish strands, okay? But sometimes easier for you to visualize when you do special staining lah, like Mason's trichome or maybe Van Giesen stain, okay? Alright, then we have papillomatosis. So what is papillomatosis? It's actually projection of the dermal papillae above the surface of the skin. So what you see is an irregular undulating configuration of the epidermis. So the skin is usually straight, right? But in this case, the dermal papillae is like push up towards the up is pushed towards outside, or the outer layer of the skin. So you have like finger-like projection on top of the skin layer. Okay. This can be due to epidermal hypoplasia, maybe because of chronic inflammation or neoplasm, and sometimes also viral infection, for example, canine papillomatosis due to papilloma virus. Okay. So I hope you can see that the dermal papillae is above. So this is like the normal skin sort of it's supposed to be straight, but here you see the dermal papillae is projecting outwards. Okay. Alright. Okay. Next, we move on to pigmentary incontinence. This is also changes that you might see in the dermis. Remember, again, as I mentioned before, the melanocytes are usually at the stratum basale. Sometimes when there is injury to the skin, there might be, release or accidental release of these melanin pigments or granules into the underlying dermis. Okay, so sometimes this melanocyte will engulf the melanin pigment, and they will also take up the stain, becoming melanophages. Okay, so it can usually happen under the epidermis layer, so subepidermis, and and also inside the macrophages. Okay. Okay, the dermis also can develop edema, so you can see dermal edema. Here, other findings that support dermal edema would be dilated lymphatics and widened perivascular and interstitial spaces. So, dermal edema, sometimes, the collagen inside the skin, usually they are like close together, but in dermal edema, there'll be gaps between the collagen layers. Okay, besides the spaces that exist between on the outer layer of the blood vessel, for example. So that is why it's called perivascular. Okay. Next, we have mucinous degeneration. Here, there will be increased amount of amorphous, stringy, granular basophilic material that separates, thins, or replaces dermal collagen, fibrils, and surround blood vessel and appendages. Mucin usually are basophilic material. So, this mucinous degeneration is a common finding in cases of canine hypothyroidism. Okay. Alright, now we look at the changes that might affect the follicles or hair follicles in the dermis. Okay, so the follicular epithelium can also be affected. You see follicular keratosis, maybe plugging of the hair follicle, or even dilatation of the hair follicle. Okay. Others can be perifolliculitis, meaning inflammatory infiltration around the hair follicle. So peri meaning around. And then even the hair follicle itself can become infected, leading to folliculitis. Or you might also see follicular atrophy. Okay, this follicular atrophy is very common in hormonal type of diseases. Okay. Other structure in the dermis, definitely you can see all the glands, the sebaceous and the sweat glands, right? So this also can be affected. You might see suppurative and granulomatous inflammation leading to sebaceous adenitis. So inflammation of the sebaceous gland. Hydradenitis is anyone can guess? No idea. Okay, hidradenitis is actually inflammation of sweat gland. Okay, sebaceous is sebaceous adenitis. Apocrine or sweat gland is inflammation is called hidradenitis. Okay, so these glands can become atrophic or even cystic in cases of hormonal disorder, or might even become hyperplastic in chronic inflammation. Okay, sometimes there can be also neoplasia of these glands as well. Okay, other structure in the dermis, you know, there are blood vessels in the dermis. So this blood vessel can also develop lesion, for example, dilatation. There could also be endothelial swelling, hyalinization, even inflammatory infiltration into the blood vessel wall leading to vasculitis and even thromboembolism. Okay, so we come to the last layer of the skin, which is the subcutaneous layer. So the common lesion that you can see in the subcutaneous is actually panniculitis. Okay, inflammation of the adipocyte in the subcutaneous layer, and steatitis. Steatitis meaning the fat tissue not only under the skin but also in the body, maybe like abdominal fat and so on. So panniculitis can be due maybe to infection. Steatitis is commonly associated with deficiency in vitamin E. Okay, so vitamin E is good to fight free radicals, or is protective against oxidative damage. So when there is oxidative damage, the fat in the body would become degenerated and develop inflammation lah. So vitamin E deficiency can actually lead to steatitis. This is quite commonly seen in cats fed with fish that are high in PUFA, or polyunsaturated fatty acid. Okay. Alright. So we've come to the end of the first lecture. Any question? But before that, yeah, perhaps you guys can fill up the attendance. This is the link. Alright, that's the link. Any question so far? 9:53.
Doctor, I have a question. I have two questions actually.
Yeah.
I just wanted to ask, like, how does epidermal hyperplasia lead to papillomatosis? Is it because when it starts to thicken and then it starts? I don't know. I don't know.
Papillomatosis is the derma papillae is projected towards outside. Okay. That's the difference. So you get like a finger-like projection. Usually, you know, have you seen warts? Warts is example of papillomatosis. Hyperkeratosis doesn't have to be doesn't show the finger-like projection. Is you hyperkeratosis is usually thickening of the stratum corneum, right? But in papillomatosis, the dermal papillae, remember the dermal papillae? is actually pushing towards outward. So you have that's how the finger-like projection is formed actually. How come not accepting any more form? Oh, sorry. Uh, okay. Is that clear? Okay.
Oh, okay. Thank you, doctor. So, and then another one kan yang uh pigmentary incontinence tu kan there's presence of melanin in the dermis. So does that like affect anything? Macam is it bad that the melanin is in the dermis?
It gives you a sort of like not a good complexion lah basically, because the skin will appear darker in that particular area as well.
Oh, okay. Thank you, doctor.
Yeah. Other than that, doesn't cause much problem lah. Yeah. Okay, I think the form should be okay now. Right. Any other question? If you have other questions, also you can ask during the practical on Friday. Right. No worries. Okay. You guys would like to take maybe like 4 minutes break, and we will start again at 10.
Sure, doctor.
Okay. You can go for your toilet breaks or even maybe drink some water. Okay guys, it's already 10 o'clock. We'll start with the following lecture, okay? Alright, for lecture 3 is basically about primary and secondary skin lesion. Remember that in the first lecture I mentioned that skin diseases can be very challenging to diagnose because there are many factors that can contribute to skin diseases, the endogenous or exogenous factor. So uh, that's why we can try to classify the lesion that we see into primary or secondary type of skin lesion in order to help us with the diagnosis of skin diseases. Okay. Alright, so for lecture 3, we'll be looking at different types of primary skin lesion and what are the type of skin lesion that classify under secondary skin lesion. Okay, so first of all, you need to know what is primary skin lesion all about and what is the definition of secondary skin lesion. Okay, primary skin lesion is actually a skin lesion that develop as direct result of disease process. Can occur spontaneously by itself. Okay, so meaning diseases or condition that lead to the formation of the lesion that you see on the skin. In comparison, secondary skin lesion actually lesion that evolve from the primary skin lesion and can be due to the patient activities. Meaning, for example, you know acne? Acne is a pustule, right? So pustule is actually a primary skin lesion. But if let's say you pop the acne, you are the one that caused the acne to rupture, resulting in formation of erosion on the skin. So erosion in this case is secondary to the pustule, and because of the pustule rupture that due to you rupturing the acne. Okay. Um, I would like to highlight that as well. If you go through any references also, some lesion can either be classified as either primary or secondary. Okay, it can fall under both categories. So example of this is, for example, alopecia. Alopecia in hypothyroidism is a primary skin lesion, meaning hypothyroidism lead to the alopecia in the animal. But in cases of, for example, flea infestation, the flea would result in the animal become very itchy, so the animal would definitely scratch itself. Okay, so the scratching would induce dermatitis or even excoriation. Excoriation meaning wounds on the skin because of the itchiness due to the flea bite allergy. So this alopecia, because of the scratching, the hair will be scratched or removed from the body. So the resultant alopecia is because of the activity of patient, not because of the direct result of the flea. Okay, so again, that's why you might see some variation in the classification of primary or secondary or even both skin lesion. Some references, the primary skin lesion include macule patch, papule plaque, nodule, tumor, vesicle or bullae, pustule or abscess. For secondary, they put epidermal collarette, erosion or ulcer, excoriation, scar, lignification and callus under secondary. But sometimes, as I mentioned, the lesion can form either in primary or secondary category. Example like scales, crust, alopecia, erythema, hyper or hypopigmentation. Okay, we'll be looking at the different types of this primary and secondary relation. But for today, I've classified this 8 lesion under primary skin lesion. Okay. So under primary, we have the macule patch, papule or plaque, nodule, tumor, pustule, wheal, vesicle, bulla, and alopecia. For secondary, we have 11 examples of secondary skin lesion: scale epidermal collarette, crust, scar, erosion, ulceration, excoriation, lichenification, hyperpigmentation, fissure, and also callus. Okay. So the first one, the macule or patch. Okay. Macule or patch is actually a circumscribed. Okay, circumscribed meaning you can see clear demarcation between the normal and abnormal part, and it's always flat. Okay, it's a flat spot characterized by change in color of the skin. Okay, if it's more than 1 cm, it is called a patch. Smaller is a macule, larger is a patch. Okay, so this discoloration of the skin can be due to either maybe melanin pigmentation or hyper melanosis, maybe due to depigmentation or hypomelanosis, and erythema. Erythema is basically reddening on the skin due to the dilatation of the blood vessel. Okay, this macule or patch can be seen in cases of allergies, hyperadrenocorticism, Sertoli cell tumor, and hypothyroidism. So I hope you can appreciate this diagram. Basically, it's a well circumscribed spot, right? You can see clear demarcation between the normal and abnormal part. It's flat, okay, and it's the color is different from the normal surrounding tissue. Okay, can be darker or lighter, maybe reddish, something like that, right? And the size will determine whether it's called a macule or patch, because if it's more than 1 cm, it's a patch. Okay. Right, example would be this. In orange colored cats, they tend to have this lesion called lentigo, usually at the mucocutaneous junction of the lips. Okay, so lentigo is a benign heritable condition of hyperpigmentation due to focal increase in number of melanocytes. Okay, so I hope you can see the dark blackish spots there. So these are called lentigo. You cannot palpate it, you can just see. Okay, it's flat, there's clear demarcation. Okay, you can see the borders of the dark colored spots on the mucocutaneous junction or even the lips lah. Okay, so again, macule is small, patch is when it's more than 1 cm. Okay, so this diagram I hope can you can appreciate better. So it's well circumscribed, different in color, and it's flat. Okay, right. Okay, you need to differentiate between this papule and plaque. So papule and plaque is basically a small, okay, it's small, it's a solid elevation. Usually it's a elevation from the normal layer of the skin up to 1 cm in diameter is called a papule. If it's larger than 1 cm, it's called a plaque. Okay, this one you can palpate. Okay, not as before macule a patch, you cannot palpate. This one you can palpate. Okay, so this can be due to infiltration of inflammatory cells, epidermal hypertrophy or intraepidermal or subepidermal edema. Okay, early stage of acne, allergic dermatitis, or even scabies, candidiasis, and dermatomycosis. These are the typical lesion that you would see. Okay. So grossly, how does it appear? So these are papules and plaques on the trunk of the dog, okay, with due to hypersensitivity reaction to a shampoo. And this is in humans, so if it's small papule, larger is a plaque, okay. Alright, next we move on to nodule. Nodule is a small, again circumscribed, solid elevation as well, that usually extend into the deeper layer of the skin. Okay, so that's the difference. It is actually deeper than the previous lesion, okay. Can be due to inflammatory or maybe neoplastic origin. Example could be leprosy, papillomatosis, or acrylic dermatitis. Acrylic dermatitis is sometimes like cats and dog. Maybe there is some itchiness at the usually at the limbs, limbs, they tend to leak at the same area, inducing dermatitis. Okay, so acrylic meaning the animal induced because of maybe usually polyneuropathy. Remember the free nerve ending, the one that is responsible for the itchiness sensation. So maybe there's a problem there, so it triggers the itchiness, so the animal keep on leaking at the same area, causing dermatitis. Okay. Alright. Okay, this is an example of that lesion. Many infectious agents and several immunologic conditions can actually cause nodular dermatitis in horses. So you can see like these nodules very very clear, raised mass. Okay. In this case, it's a calf with lumpy skin disease due to pox virus. Okay. Alright, next we move on to tumor. Tumor is definitely neoplastic enlargement, usually very large size, can be composed of any structure of the skin or subcutaneous tissue. So you know the skin and tissue have the skin has different layers, and then there are many structures in the skin. So if it's fat tissue, what do you call tumor of the fat tissue? This is going back to your Pathology 1, neoplasia. Anyone?
Lipoma, doctor.
Yeah, lipoma or even liposarcoma, very good. So fibroma is due to the fibrous connective tissue or fibroblast. Melanoma is associated with the melanocyte or melanin pigment, right? Carcinoma could be anything, maybe like squamous cell carcinoma, right? Okay, so this is example of neoplasia, okay, or tumor. So this is a case of cutaneous epitheliotropic lymphoma in a dog. So if you were to take a sample of this, you definitely would see numerous lymphocytes, okay, in the sample, okay, and usually it is localized at the epidermis. That's why epitheliotropic, okay. It is very fond or has tropism at the epidermis, okay. Right. Next, we move on to pustule. Remember, I told you about the example acne. So acne is a form of pustule. It's a small circumscribed elevation of skin, usually filled with pus. Okay. So that's the difference. It is usually contain pus. So example acne, cases of demodicosis can also you see pustule a lot. Dermatomycosis, pyoderma, and pemphigus foliacea. So this I have mentioned many times in the previous lecture. Pemphigus foliacea, you see the pustule. Okay. So this is an example how pustule looks like grossly. So this is an udder with many pustule. Okay. And this is a dog with pemphigus foliacea, so pustule. Okay, you can see the pus on the skin, and then the reddening is the erythema actually. Okay. Alright. Next we have wheal. Wheal is sharply circumscribed. Again, it's well demarcated. You can differentiate the borders, or you can see the lesion very well. It's usually raised and is made out of edema. So example is urticaria, or also known as hives. Allergic dermatitis can be due to flea or insect bite. So you know when you get bitten by mosquito, you get the wheals on your skin, right? So that is very, common example, mosquito bite. Okay. So this is a gross image of what wheals should look like. Wheals are most commonly seen with hypersensitivity or allergic disorders in horses and less frequently with dogs. So these are what wheals look like. Okay. Next, we move on to vesicle obula, okay? So vesicle obula basically are sharply circumscribed elevation of the skin filled with clear free fluid. And the size, if it's more than 1 cm, is called a bula, okay? If it's lesser, it's called a vesicle, okay? This one is yeah, as I mentioned before, example, very common example is the blister. But you can always see this type of lesion in allergic contact dermatitis, dermatomycosis, or example vesicular exanthema like the swine snout. Just now I show you the vesicle or bula. The cyst or fluid fields set on the skin, okay, due to the calicivirus, okay, this one, vesicle exanthema, okay, this is a bula because it's definitely bigger than 1 cm in diameter, and this is example of contact irritant dermatitis forming vesicle on the skin. This is one, and then there are here actually, if you have a good look, okay. Alright, next we have alopecia. So remember alopecia, some people can categorize it under primary or secondary, but in this lecture I put it under alopecia under the primary skin lesion. So alopecia is the loss of hair in areas where they are normally present, okay? Partial or complete loss of hair. The distribution can be diffuse, meaning the whole body is affected. It could be regional, it could be multifocal or even focal, okay? Many factors can actually lead to alopecia, for example, hormonal like hypothyroidism, nutritional, okay, you see like dogs or cats with not enough nutrition, usually the hair won't grow very nice, or they don't have much hair going, okay. Autoimmune also can lead to alopecia. Sometimes, you know, when they attack the skin, definitely the skin will become damaged, or even the hair follicle also will become damaged. That's why there'll be no hair growing there. Stress also can lead to alopecia. You know, during stress time, a lot of hair will be shedded. Okay. Parasitic also can lead to alopecia, bacterial infection, allergy, even trauma. Okay, so here I put hypothyroidism, hypoadenocorticism, mange, pemphigus, allergy, dermatitis, and psychogenic alopecia. Psychogenic alopecia meaning that there is mental sort of mental problem lah basically in the animal. Usually this is typically seen in cats mostly. These cats maybe out of boredom, for example, or maybe they are stressed, they tend to overlick themselves. Cats usually groom themselves, but this one is over grooming. So when they overgroom, definitely there will be excessive loss of hair. Okay. Hormonal type of alopecia tends to be symmetrical in distribution. So if it's usually affect both side of left and right side of the body. So that's like a clue to indicate hormonal type hormonal disorder. Okay. Alright. First question, which is not a primary skin lesion?
Ulcer.
Yes, very good. Very easy question. Right, next question. Which one can be a primary or and also a secondary lesion?
Pigmentation disorder.
Yes, very good. Alright. Now we move on to secondary skin lesion. Alright. Scale. Okay, scale. Easy to remember. Just remember dandruff, basically. Not dandruff, I mean like scabs lah basically. It's a flaking of stratum cornea or accumulation of loose fragment of the horny layer of the skin, final product of epidermal keratinization. This is commonly seen in allergic dermatitis, endocrine disorder, dry skin, seborrhea, and dermodicosis. So basically the stratum cornea easily slough off lah. Okay. Yeah, this is an example of scale. So you see in cases of chronic seborrheic dermatitis, you see a lot of scaling. Okay. Next we have epidermal collarette. So epidermal collarette is actually circular lesion. You see very clear circular lesion on the skin with rim of circular rim of scale. Sorry, circular lesion with circular rim of scale. So it's like the corneum layer is almost coming off at the border, and then it can also be easily peeled off. Okay. So most of the time the border would be reddened or erythematous. Okay. Central area of hair, central area usually doesn't have hair. Okay, and this is often associated with vesicular or pustular lesion that has ruptured. Like that pop acne also can actually lead to epidermal collarette. Okay, if it's very big lah. Okay, epidermal collarette also are typical finding in canine pyoderma, insect bite, and even fungal infection. So remember, it's a circular lesion with circular rim of scale that you can actually peel off. And then the borders are usually red in color because of the erythema. Okay, and the middle part is always hairless. Okay, then we have crust. This is very clear one, like scabs lah. I mean, if you have like maybe wound, you have the scabs there. So a dry exudate on the surface of the lesion. This dry exudate can consist from either from serum, maybe pus, blood, scales, or medication that adhere to the surface and often mingle with hair. Okay, cases that you would see crusting include demodicosis, dermatomycosis, solar dermatitis, scabies, and pyodermas. Okay. Alright, this is an example of a cow with idiopathic photosensitization. So the typical finding is the formation of crust on the skin. Okay. Next we have scar. So scar is an area of fibrous tissue that has replaced the damaged dermis or subcutaneous tissue. Usually can be depigmented. Usually it's like paler in color. And if the damage is severe, leading to the hair follicle damage that is beyond repair, so that area will become hairless. So this is typical in cases of deep pyoderma, deep wounds, and abrasion, thermal and chemical burn. So if it's superficial, meaning the healing can occur very good or very excellently. So there maybe not that much lesion that you can see. But if it's very deep, that's where you can see that the hair will not grow anymore, and usually the area is depigmented. Okay. Okay, this is an example of scar. Next, we have erosion. Erosion is actually denuded epithelium with the basement membrane still intact. Okay, and hair follicles are still okay, so they are still preserved. So healing can occur very well without no scar formation. This is very typical of cases in cases of impetigo, pemphigus, even burns. Burns, there are a few types of burn. This is like the superficial burns lah, that doesn't involve the basement membrane, yeah. And yeah, consequences of rupture pustule, like acne. If you pop the acne, it can become erosion. So if the acne is very small lah, and then even rupture vesica abule also will cause erosion. Okay, ulceration is basically a break in the continuity of the epidermis. So you see that there is clear discontinuity of the epidermis with the underlying dermis exposed, and here definitely the hair follicle are all destroyed. So scar will be the aftermath after total healing has taken place. Okay, Ulcer is a common finding in cases of squamous cell carcinoma, burns that are more deeper, and then basal cell epithelioma, pyoderma, pemphigus, or even severe autoimmune disease. Okay, these images show how the ulcers look like. So usually the ulcer, you see discontinuity of the epidermis, right? And that is very deep also. So it affects the underlying dermis. So this healing usually takes longer time and more often will lead to formation of scar. Okay. Next we have excoriation. Um, Excoriation is basically superficial removal of epidermis caused by scratching, biting or rubbing or self-inflicted trauma. Okay, this is a typical finding in scabies, allergic dermatitis, acute moist dermatitis, or even for example, cats and dogs with otitis. Otitis is basically inflammation of the ears. Okay, the ears are infected, but somehow they tend to scratch their ear pinna or maybe the areas behind the ear. So you think that maybe sometimes the owner will present the animal with the because of the skin lesion on the behind the ear pinna or around the ear, but in actual fact it is due to the otitis in the ear, the infection in the ear that the animal is scratching. Okay, so that's why it's called a secondary skin lesion, or even like scabies or maybe ticks or flea on the body induces itchiness. So the animal tend to scratch or maybe bite or maybe constantly rubbing on the area, leading to this wounds or excoriation on the skin. But it's usually superficial, meaning only the epidermis layer is affected. It's not very deep. Okay, so these are examples of excoriation. So these are basically self-inflicted injury because of another underlying problem. Okay. Alright, next we move on to lichenification. Lichenification is defined as thickening and hardening of the skin, characterized by exaggeration of the superficial skin markings. So, people would say the skin looks like an elephant skin. Okay, this lesion is typically found in cases of acanthosis nigricans, allergic dermatitis, ovarian imbalance, and even malassezia infection. So remember, I told you that it looks like an elephant skin. So this is lichenification and also alopecia because there's loss of hair. Okay, this example in a cow with sarcoptic mange. Okay, the area the skin basically become very thick. All right, and then we also have hyperpigmentation. So hyperpigmentation is, as the name implies, excessive coloration of the skin caused by increased deposition of melanin. This can be due to ovarian imbalance, scabies, dermatomycosis, demodicosis, or even hypothyroidism. Okay, so definitely the skin color usually maybe not that dark, but here you can see the dark discoloration on the skin. Okay, so there is hyperpigmentation. Right. We can also see hyperkeratosis. So hyperkeratosis is increase in thickness of the horny layer of the skin. Condition that can lead to hyperkeratosis include acanthosis nigricans, male feminizing syndrome, canine distemper, and dermatophytosis. So like canine distemper is very typical. You animals with canine distemper, especially the foot pad and the nasal planum, they tend to become very, very thick and roughened. So that is one of the telltale signs of dogs with canine distemper. Okay. This is example of hyperkeratosis. So the foot pad become very, very thick. Okay, this is the nasal planum. Okay. Alright. Next one on the list is fissure. Fissure is defined as a linear cleavage. So this is like a cut, very linear cut in the skin into the epidermis or through the epidermis into the underlying dermis, caused by disease or even injury. This can be found commonly in dogs with hepatocutaneous syndrome, and even in footpad hyperkeratosis. This one, footpad hyperkeratosis, sometimes is very commonly observed in older animals, maybe like old dogs. Their footpad become very thick. So when the footpad become very thick, they tend to cause fissure or wound, and then this can lead to lameness. So please check if especially old animals, when they are lame, please check also the footpad. Maybe this is due to the fissure from hyperkeratosis, footpad hyperkeratosis. Okay, so fissure, yeah, I hope you can see like this one. There is a break or linear cleavage in the skin. Okay, so this one nasodigital hyperkeratosis. Okay, nasal and the digit. Most of the time the cause is unknown, so it's idiopathic. Yeah, commonly seen in old dogs. Okay, in humans, typically cracked heels are a form of fissure. Okay, dried cracked heels. Okay, so next we move on to callus. So callus is basically thick, firm, hyperkeratotic, hairless plaque with increased skin folds, wrinkles or fissure that develop following repeated friction or pressure or irritation. You would normally see this in at the body prominence, such as the elbow, sternum, or side of the digit, because of the constant or chronic friction pressure. These are pressure points. So they are like normal things to find in old dogs as well. I mean old dogs. Yeah, old larger dogs especially, because of the constant pressure on the bony protuberances. Okay, so this is the end of the lecture. This is just against to summary of primary and secondary lesion. You can have a look later on when I pass you these notes, so you can see the difference between the how to differentiate between the lesion and some of the common condition that can lead to the formation of this lesion. Okay, so any questions? Okay, it's 10:34. For practical this Friday, we'll be looking at images, and then I'll be giving you questions. So you need to answer the question based on the projected images. So for group 1, you will be at MM1, right? So because I'll be handling alone, so I need your cooperation to come on time at 2:30 p.m. And for group 2, you can come around 3 o'clock, okay, at MM2. Okay, so that I can settle with group 1 first, and then explain the answers for the question for group 2 after I've completed with group 1. Okay, so because I think first week is always very critical. People are going around checking whether teaching and learning is happening and whether people are adhering to the SOP. So uh, I think I have no option but to have the physical form of practical rather than the online. When actual fact I can do it online. But yeah, any questions? The practical this Friday will cover lecture 1 until 3 lah. Okay, all the just to make sure you understand the concepts and the terms that I have introduced you from lecture 1 until 3. Okay, to enhance the your understanding. Okay. Yeah, any question? If there's none, then I'll see you this Friday.
You were doctor.
All right. Thank you very much.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you,
Thank you,
doctor.
doctor. Have a nice day.